All right. Good evening, everyone. Together with my co-chair, Carmen Meer, it's a true pleasure to welcome you to this webinar organized by the European School of Urology. Tonight's session is a joint initiative of the EAU sections of Urological Imaging and Oncological Urology, and we are delighted to have you with us tonight. In this webinar, we will recreate a multidisciplinary tumor board using two real-world cases as our framework. And through these cases, we will explore a range of practical and clinically relevant topics in the management of bladder cancer. Before we begin, I'm very pleased to introduce to you our expert panel for this evening. We are very grateful for their time and expertise. Veera Nashar, radiation oncologist, Marcus Eckstein, pathologist, Shilpa Gupta, medical oncologist, Marina Pecoraro, radiologist, Oscar Faba Rodriguez, urologist, and Gauthier Marc, and of course Carmen Meer. We warmly encourage you to participate. Please share any questions you may have during this webinar. We'll make sure to address them throughout the session. And with that, it is my pleasure to hand over to Gauthier Marc, who will present the first case. Gauthier.
Hello, everybody. So Gauthier Marc, I'm an assistant professor of urology in Lille University. I'm very glad to be here, and I'm going to walk you through case number 1 on high-risk BCG-naive NMIBC, and we're going to talk a bit about intensification therapies. These are my conflict of interest. Let's dive right away in the first case. So it's one of my patients that I saw in the clinic this year. It's a 65-year-old male, recently retired, former worker in the paint industry. His past medical history is quite the usual for a bladder cancer patient. He had hypertension, type 2 diabetes, a stable coronary artery disease with a single state placed 10 years ago, an history of an appendicectomy. He is an ECOG-1. He is a current smoker of 30-pack years. His current medicines are here, quite unremarkable due to past medical history, but he has aspirin. He recently had gross hematuria for 2 months without clot retention. He had no irritative symptoms at the initial clinic. And so my initial evaluation used white light cystoscopy and revealed a 2 centimeter sessile lesion on the left lateral wall with additional flat erythematous area on the posterior wall. So the first question that I want to ask tonight to the panel is to my fellow urologist, what will be your go-to TURBT? What kind of TURBT will you perform for this patient?
Okay, I think that in this case, thank you, Mark. Thank you. I think that in this case, one of the most important goals is to achieve a complete TURBT and avoid the possibility of residual tumor, because for the aspect and for the possibility of CIS, we have some kind of arguments to really think that this case might be a high grade. In this sense, we can perform a classical TURBT, and also we can perform an en bloc TURBT. Because I think that the objectives are 3. First of all, avoid the rate of residual tumors, and all the clinical trials that we have in en bloc have assessed as primary objective the residual tumor, and the majority of those clinical trials have demonstrated that the proportion is less. We have conducted our specific randomized prospective trial, and in our case, we didn't find differences in residual tumor, but we could find differences in substaging. That is another important predictive factor. And the third point is the oncological outcomes. Up to now, we haven't had results on differences in oncological outcomes, but also we have some literature, recent literature, that have really demonstrated differences in oncological outcomes. So for these 3 reasons, this tumor in a center with experience in en bloc can be perfectly performed by en bloc resection, because with this, you can have a better substaging, less residual tumor, and this is not a question that has answered strongly up to now, but possibly in the future also better oncological outcomes.
Okay, so if I sum up, en bloc TURBT will be needed for this patient if possible. Any other enhanced imaging modalities, Dr. Mertens, that maybe you will offer to this patient?
Well, just another question for Oscar, because there is a flat red area. Would you also perform random biopsies? And what about the prostatic urethra?
Sure. In our center, we also perform random biopsies in all the primary tumors because we have a higher incidence of CIS, global CIS. But specifically in this case, if we has a suspicious of a high-grade tumor, random biopsies should be performed, and specifically a biopsy of the prostatic urethra.
I have a question for you, Oscar. Would you take the biopsy of the urethra with a loop or with a cold cap?
You can do both. I think that if you have the verumontanum, the maximum possibility of having ducts of the prostate is between 5 hours and 11 hours. So if you take a cold cap biopsy over there, you can have representation of the prostatic ducts and you can have a good sample. But if you do it with a loop, taking more sample also is correct. We are doing it with the cold cap biopsy, but both options are perfectly correct.
Mm-hmm. How about you, Gautier? Do you also perform biopsies that way?
Yeah, usually I will guide my biopsy with enhanced imaging modalities such as PDT or NBI if available. So here I will schedule the patient for an enhanced en-bloc TURBT, enhanced modality. So in my center, usually my practice is to do PDD. So I will schedule this patient for a PDD, and regarding the question of the urethra, if my PDD is negative and I have a solitary lesion and my PDD is negative in the bladder, I won't directly perform prostatic urethra biopsy.
Mm-hmm. Okay. How about because we are doing a white light cystoscopy?
Yeah.
Would you get a cytology at the time of cystoscopy, and would that change anything for you, either of you?
Well, at that time, you're gonna go to the OR anyway. I usually like to have a cytology before I go. If you have a high-grade cytology and on the white light cystoscopy and you perform your TURBT and you end up having a PTA low grade, you can always compare your cytology and say, and if you have a high-grade cytology, you may have missed the CIS. So I guess I always perform a cytology when I do my white light cystoscopy, at least for primary cases,
Okay.
which is the case here. So I will consider the urinary cytology at the time of my white light cystoscopy.
That's good. And we would do you would suggest also an en bloc because of the size of the tumor is
Right.
small, so it's feasible in order to
Exactly.
get it completely as Oscar suggested. Okay.
Yeah.
How
And
about
yeah,
keep
sorry.
going. Keep
Dr.
going, keep going.
I had another question for Dr. Pecoraro. Will you consider any imaging at this point? And if so, yeah, and if yes, which one?
Yeah, well, I would consider MRI for the reason is that it looked sessile during cystoscopy. So that's the reason why I would suggest to do an MRI.
Okay. So that's what we did, and here
Hold on,
yeah,
I
the
think
imaging.
Oscar has a question.
Sorry.
Only a specific point regarding two other imaging studies. I think that not specifically, maybe in this case, but all tumors that are located in the trigone or all tumors that have a high-grade appearance, I think that it's important to rule out tumor in the upper tract, and a CT scan at diagnosis would be an option. A CT scan in order to rule out upper tract tumor.
Right. You're right. Okay, let's go back to the MRI then.
Maybe Martina can tell us a little bit more about the MRI part?
Yeah, I can comment the images. So here what you see are T2 weighted images, which are basically the morphological ones. Very useful for you to assess the location of the tumor, in this case, the anterior wall, more on the left. And it also helps you to check for some specific characteristic of non-muscle invasive bladder cancer, which is the presence of the stalk. So stalked lesions are most of the time non-muscle invasive. And you have the confirmation on the DWI and ADC map, as well as after the images after contrast. So basically what you see there, it's like that black dot below the white signal. So that's the lesion with the black dot, that's the stalk, which is complementary on the ADC map, it's white. So that's a stalked lesion. And if you see at the post-contrast images, you also have one very nicely seen on the third image, post-contrast. You see that there is a linear enhancement below the tumor, and that is called the inner layer enhancement, which is basically the mucosa below the tumor that is inflamed. So this is caused by inflammatory changes, and this is a sign of non-muscle invasive bladder tumor. So this could be easily classified as a virus 2, so non-muscle invasive bladder cancer. And actually, there's no need to go up to 1,300 on the DWI, technically. 1,000 at the DWI will be fine as well. It's not as in prostate MRI, in which you have to have a high B value. On bladder MRI, is just like any other pelvic imaging. The important thing is that the field of view is small. So as the prostate, it needs to be of high resolution images. And the most important thing here, technically, is to achieve an appropriate distension of the bladder, whenever you take the images. So, for example, in this case, it would be better to be more distended, because if you see it, the anterior wall is slightly convex compared as in if it would be fully distended. And one way to check it is to see if the bladder dome in sagittal images, not as in this case in the actual, but you can see it also from here. In the sagittal plane, if it is convex, then it's good. It's a good distension. That's a trick. And you can acquire images on both 1.5 and 3 Tesla scanners. Nowadays, the scanners are most of the time in Europe. They are updated, the 1.5, so the images are good enough also on lower field scanners. And contrast is needed, as I told you before, because of the enhancement of that inner layer, which is the mucosa and the lamina propria together, can be seen only on post-contrast images, cannot be seen on any other sequence. The downfall of the MRI is that we cannot assess the presence of CIS, carcinoma in situ. That cannot be done.
And Martina,
Yeah.
now we have a relatively small sessile bladder tumor.
Yeah.
What would, in your opinion, be the clinical consequence of performing an MRI? What would be the clinical benefits? Can you explain?
Yeah, in this case, we have excluded that the lesion that you saw, it's a sessile during cystoscopy, is not muscle invasive, at least on imaging. So I guess you could treat it with TURBT more safely.
So is there, from your point of view, a patient that would actually 100% benefit from doing the MRI? My point is, like, we cannot access MRIs.
Yeah, right.
So
In my opinion, those are patients that you as urologists think that is most likely muscle invasive tumor. If you see a papillary lesion on cystoscopy, even if it's, 3 centimeters or something, or even higher, but to you it's clearly papillary, then I don't think MRI would be that useful in the diagnostic pathway of the patient. But even if you see, as in this case, a 2 centimeters lesion which looked as sessile, I think MRI is useful, because in the MRI, in muscle invasive setting, the usefulness of MRI is also concerned, it's related to the possibility of having the assessment of the response to chemotherapy or whatever neoadjuvant systemic therapy they can undergo too.
Okay, we can maybe discuss the next case a little
Yeah,
bit
sure.
more. Okay, let's move forward with you.
Yeah. So, as explained, that the MRI show an anterolateral virus 2 lesion. It was also sent to the professional exposure clinic due to this occupation, and a smoking cessation clinic. The TURBT was performed en bloc with using blue light technology, and the pathology came back as a PT1 urothelial carcinoma, PT1 high grade, and positive blue light area were assessed with using cold cup biopsies that show carcinoma in situ. Dr. Eckstein, at this point, any other pathological factors that may be useful here?
So what we are in general reporting on each sample, if it's present, is, for example, lymphovascular invasion, but it's a super high risk feature for T1 carcinomas in general, but it's extremely rare. And in case of a lymphovascular invasion being present, we usually doubt that it's a true stroma invasive tumor and not probably a muscle invasive disease that might not have been covered by the transurethral resection. But in addition, beside the standard pathological classification of the tumor stage, the grading that is of, I would say, less importance in this situation, and reporting if a carcinoma in situ is present or not, there are no additional established risk factors that we are currently reporting according to standard reporting guidelines. The only thing that also from the EAU guideline is usually recommended to be reported is the WHO grading from 1973. So it usually should always be reported if a T1 is G2 or G3, because there is evidence that G2 tumors have a lower risk of progression than G3 tumors.
Okay. Okay, and regarding the way to assess for CIS, do you have any recommendation as a pathologist on the way we should assess the presence of CIS? Will you prefer cold cup biopsy, standard loop resection? What is in your opinion the best way to do it?
So in general, it really depends on. In general, it's very favorable to have multiple random biopsies, and also from locations that appear to be suspicious in the cystoscopy, especially in the blue light cystoscopy or narrowband imaging, whatever you're in general using. And cold cup biopsies are, from a morphological and a pathological point of view, preferable because we're not dealing with thermic alterations. And thermic alterations can really deteriorate the assessment of carcinoma in situ. What I also recommend everyone who's present here is, in such a scenario, if you have a first diagnosis, maybe not of a T1 carcinoma, which is already a high risk situation, but for example, let's say a PTA, a non-invasive tumor with G2, for example, and high grade, which is not a super high risk constellation. And in addition, a carcinoma in situ reported without having it verified with immunohistochemistry, I would always ask for that. Because in this situation, it really matters if the CIS is a true CIS or might not be only an accompanying shoulder lesion of a tumor, for example. That's something that you could ask, especially in critical scenarios, if it would make a difference between high risk or very high risk classification.
Oscar, there is a question here that I think you could answer. They are asking, why should we do a prostate urethra biopsy if we are doing the cold cups?
Yeah. So because we know that the prostatic urethra involvement, it's a predictive factor for progression in T1G3. So in all the cases where you suspect the possibility of having this specific predictive factor, like in this case with a positive cytology, with a tumor that is a high grade, prostatic urethra biopsy should be performed in order to have the urothelium and also the prostatic ducts, because the involvement of the urothelium and prostatic ducts is different prognosis, and also can really select the patients that can go straight for a radical cystectomy, or those patients that can be managed by a conservative approach. But the specific answer to the question is because it's a predictive factor for progression, like other ones, like perhaps female or substaging or lymphovascular invasion.
Thanks. Let's keep moving forward, Gautier.
Yeah, Laura?
Yeah, just one quick question, also excellent question from the audience. Why are we calling this sessile? It's a question for Martina, I think.
Yeah, actually on MRI, it was pedunculated, stalked,
Yeah.
whatever you want to call it. Sessile, it looked on cystoscopy.
Yeah, thank you. Continue,
Okay.
please.
Sure. Let's move forward. Yeah. So regarding the management, we perform also a single look TURBT, and I want to stress out here that the timing of the single look TURBT is of matter. The additional pathological data that we have from the initial TURBT, there were no subtype identified. There was actually a lymphovascular invasion, although we heard that is rare. The muscle was present and free of invasion, and the second look TURBT performed 4 weeks after the initial TURBT showed no residual lesion, but the persistence of CIS. So at this point, the first question to the panel is, how will you consider this patient? Will you consider high risk, very high risk? What will be your risk stratification?
Oscar.
Okay, I think that for me there is no doubt that this is a very high risk non-muscle invasive bladder cancer, because we have a lot of predictive factors that can put this patient in the box of very high risk, like the CIS, like the lymphovascular invasion, and these are 2 reasons at least to consider this patient in the very high risk group.
So what would you do, Gautier?
So for this patient, I went for BCG alone, BCG induction and maintenance. Will you use radical cystectomy in such patient prior to use BCG, Oscar?
The patient has to be informed, at least, because I think that this is a very high risk, specifically as Dr. Etke has said, lymphovascular invasion is very rare, and when we have lymphovascular invasion, prognosis is not good. And this patient, according to the guidelines, radical cystectomy is the first thing that we have to talk with. So if finally we consider to go to BCG, and the patient has CIS after RET-UR, another predictive factor. So is the CIS after RET-UR, persistent of tumor after RET-UR, lymphovascular invasion, CIS. So at least the patient has to be very, very well informed that the probability of progression is high, and we have to talk with the patient about radical cystectomy, and according to the European guidelines, the first option would be radical cystectomy.
Okay, Dr. Gupta, will you offer any other systemic therapy for this patient?
At this time, I would not, since this is a BCG naive patient. BCG alone is the standard right now. We have seen the BCG plus immunotherapy data, but again, it's not an approved option right now. So at this point, I would not offer anything else.
Shilpa, can you tell us a little bit of your thoughts on these 3 trials that recently came out in BCG naive setting, and some differences in the times of treatment and the
So we have seen 3 trials, and the CREST trial used BCG plus saselinimab, which is a checkpoint inhibitor. And yeah, thanks for pulling that out. And then we had the Potomac trial, which was also BCG plus durvalumab, which is a systemic PD-L1 antibody. And the Alban trial was with atezolizumab. So in the CREST trial, we did see that the primary endpoint was met of event-free survival. And it was more, the benefit was seen more in patients who had CIS positive disease. There was obviously no overall survival benefit. there was 2 years of systemic checkpoint inhibitor in the CREST trial. In the Potomac trial, there was 1 year of durvalumab, and the primary endpoint was also met in the Potomac trial. And in the subgroup analysis, we did not see that there was more benefit for CIS patients. So it was different from the CREST trial. However, I will say, not doing cross-trial comparisons, but in the CREST trial, the checkpoint inhibitor related toxicities were quite a bit, especially with the 2 year of exposure. And in the Potomac trial, they were a little less compared to that. An Albert trial was actually a negative trial that was reported. This was an investigator-initiated trial, not a global trial. And there's a lot of talk about different strains of BCG used across trials, and would love to hear what you all think. So I think there's, we'll see whether these agents will get approved or not, because for lack of, we have not yet seen the data for cystectomy outcomes. How many patients needed salvage cystectomy? We have not seen that for any trial. So without that, offering this blindly to patients with so much financial and other toxicity, I think there needs to be discussion, and we'll see what the regulatory authorities say.
Do you think that is the differences in toxicity are related to the timing, like longer exposure definitely, and with seems to add up, no?
Yeah, I would think so, with the longer exposure, and that's PD-1, PD-L1. I don't think that makes much a difference, but 2 years is quite a lot in that setting, probably.
Okay.
And also, we've shown in these trials, or we've seen in these trials, that one could not get away without BCG, right? So BCG is still the mainstay here. We really don't know how much the IO is adding, because you've not seen other benefits.
I think Oscar has a comment.
Yeah, it's a comment for Shilpa, because I don't know what's your opinion, Shilpa, but despite that Potomac and CREST trial are phase 3 trials where all tumors of high risk have been included, I think that considering the toxicity, grade 3, that you have stated, and also the possibility of progression, the feeling, because we don't have the data, but the feeling of all urologists now here is that the patient that can benefit most for these combinations, Potomac or CREST, is this patient that we have presented today here.
Very high risk.
About radical cystectomy. I don't know what's your opinion on this.
So you mean instead of upfront cystectomy,
yes,
where you would offer to a patient with very high risk disease, that is the patient.
Exactly.
Yeah, I mean, there needs to be some certainly selection criteria for offering. I'm not saying the benefit won't be seen in anybody, but we really need to know which patients will benefit.
It's actually a perfect introduction for the next slide, because Professor Xilinas recently presented at the MU Congress the result of the CREST data in the very high risk population, and you see the magnitude of benefit that you see for this very high risk patient is much better than what we are seeing in the overall population. Although we have to acknowledge this is a limited number of patients, and the trial was not designed to answer this specific question. Thank you. I think we are almost to the end of the case. I just want to highlight that for this patient, I choose BCG induction and 3-year maintenance. And the last question I want to ask to the panel will be in case of BCG shortage, what will you offer to the patient? And to Dr. Achar, if there are any upcoming role for radiation therapy in this patient population.
So may I
Dr. Achar? Sure, please.
Thank you very much, Gauthier. There is a very interesting randomized control trial, phase 3 trial of Professor Ananya Chuduri, that the TRAIN trial that is led in the UK, and that will compare BCG maintenance versus radiochemotherapy for this patient, BCG injection and maintenance, sorry, versus radiochemotherapy. So if it works, this may be an option in case of BCG shortage or in case of BCG adverse events for this type of patients.
Oscar?
What about CIS and radiotherapy, Dr. Achard? Good friends or not?
Just made a review this year. In fact, there is this claim that CIS is radio-resistant. We looked at the data, and basically what we can say is that we don't know. It may be radio-resistant, but also we don't know because the quality of the data was very low. It was old radiotherapy with no radiosensitizer. It was not correct doses. So and the results are very they are conflicted results. So we really don't know, and we need to do more proper trial in order to address this specific point of CIS radioresistance.
We have a question to be answered. What size of tumor, like is that some colleague is asking about, the 10 centimeters high-grade T1 tumor. Would that change your approach in order to going for primary radical cystectomy versus going for endovesical therapy like BCG? Maybe Gauthier, you want to answer?
So the question, sorry, is about the size of the tumor.
If like a large tumor, 10 centimeters, if you are able to completely resect.
Exactly. That will be my point. So we know that over 3 centimeters is one of the risk factors that also allows you to correctly re-stratify your patient. But if you are able to fully resect the patient, and even though you have a large mass, I will still be keen on treating him or he or she like I treated this patient. Everything is based on the quality of the initial TURBT, and that's why I want to stress out that this surgery should be performed at the first time. She should be perfectly performed right away.
So in order to summarize, thank you so much. I think we are lacking still biomarkers that can help us identify patients that might progress. That's a major lack that we have. Thank you very much for the discussion. We move, Gauthier, you did a great job. I think we already know what to do now with these cases. Let's move into the second case, and Oscar is going to try to articulate amongst us.
Thank you, Karma. It's very interesting because now we are moving forward for the natural history of a patient that have failed to BCG, like the previous one or like the patient that I'm presenting now. So this is a patient, it's a 66-year-old patient. Comparing to the previous patient, there is no any specific occupational habit that might increase the risk of bladder cancer, not toxic habits like smoking, no other relevant history. The patient started with hematuria in another hospital. There was performed initial TURBT that the pathological results was ATX, low grade, and the patient didn't receive any kind of adjuvant treatment because the urologist at that point considered that was a low-risk patient and decided not to treat this patient with any adjuvant chemotherapy or any adjuvant treatment. After a couple of months, the patient started with irritative symptoms. Initially was considered that was some kind of hyperreflexic bladder, was treated with anticholinergics, but quickly was performed a cystoscopy that was normal, no exophytic lesions, no other suspicious lesions, but a cytology that was positive. The urologist, in order to rule out some kind of a tumor in the upper tract, performed a CT scan, and because of the positive cytology, we put the patient in the ward. In our protocol, those patients that have positive cytology and normal-looking cystoscopy, we go for random biopsies, and we rule out upper tract tumor with a CT scan. So at that time, as you can see here, the surgeon performed random biopsies and also a TURBT of this flat erythematous lesion that was completely removed. I want to state that CIS, because we have many residents, it's a pathological concept, it's not a clinical concept. So the diagnosis of CIS is a pathological diagnosis. And we, the urologists, the only thing that we can do beside the random biopsies is to make a biopsy of this kind of areas that are erythematous, flat lesions. And in this case, we can really also have suspicions of CIS. But after this TURBT, this is the pathological result. We made the random biopsies of the bottom of the bladder, right side, left side, the anterior part of the prostatic urethra. And there was a multiple CIS in all the random biopsies, excepting the prostatic urethra. And in this case, we had no dots in the random biopsy. Okay, so this is a multiple CIS. This is a high grade, high risk, non-muscle invasive bladder cancer. And at this point, considering that up to now, the patient is non-muscle invasive, I'm trying to reinforce some concepts that we have discussed a little bit before. I would like to ask to the panel the specific indications that you consider for the PDD or MBI. We know that the European guidelines consider the use of PDD in these cases of normal-looking cystoscopy with positive cytology. And do you think this is correct? Only in these cases, all the patients with initial bladder cancer should go under PDD? So this is a question for Dr. Gautier or for Laura or for Karma, that are the urologists that we have in the panel.
Sure, I'm happy to answer this question. I think your cases really nicely highlight again the fact that the initial TURBT, the quality of the initial TURBT is paramount. And here, for your case, I will surely use an enhanced cystoscopy imaging. And you name it, PDD or NBI, but I will definitely use here during my initial TURBT enhanced method for detection, because we know from large meta-analysis that you can increase up to 50% the likelihood of finding CIS in those patients. So I definitely use PDD for this patient.
Okay. Any extra comment for this? But you can see here how, with random biopsies, PDD might not give you any extra information. And random biopsies are
right.
cheap.
I think you're right. So you have two options. So either I think the what you perform is the other way around, right? Is if you do an enhanced cystoscopy, then you target your biopsy. If you don't have the ability, then you do exactly what you showed us, right? Random biopsy to make sure that you assess most of the area, and you target at least two. At least in my own practice, I do two cold cup biopsy per area of the bladder, including the prostatic urethra, when I don't have enhancing imaging modalities, cystoscopy modalities.
Yeah. In our experience, any extra indication besides this indication for CIS of PDD might be to complete the full resection of the borders, of the edges of the tumors. Sometimes you complete the resection with white light cystoscopy, and you say, okay, this is okay. My resection is complete. And then you put the PDD, and you can see a little bit of extra enhancement in the borders that you can remove. And in order to have a wide and complete resection, maybe this can be an extra indication in some cases for PDD, is what we are doing in our...
I agree, but we need more data to support this approach.
For sure.
And also a learning curve is an issue with a learning curve, because sometimes the images can be confusing, and you
exactly
don't know exactly how far. So if the PDD has been there for too long, the intravesical has been there for too long, then it can also misguide you. So there are a lot of conflicting concepts about the PDD.
I fully agree. There are pitfalls, yeah, sure.
Okay, so here we have a nice pathologist to really address the second question. What about molecular markers? We have our nice cytology in this case. We have tons of literature in the last years. We have a guidelines, European, that doesn't specify which marker and when. And maybe Dr. Edke can really make us a brief summary on this.
Yeah, sure. So I think the same what we were already discussing for the previous case also applies to this case here, because of course in the non-muscle invasive bladder cancer space there were numerous publications about genetics and molecular subtypes that indicate certain high or low risk constellations, mainly stemming from the group from Lars Dyrskjøt and Aarhus in Denmark. But overall, it's pretty clear that nothing of these approaches to subtype non-muscle invasive bladder cancer or CIS have been introduced into clinical practice for now. So right now, there is definitely no biomarker that is ready for prime time, which is a pity, I think. Mostly also due to the fact that prospective studies on these risk stratification factors are lacking. And I think right now, and maybe that's a philosophical discussion, we're not in a time anymore where we can hide behind costs for transcriptome sequencing, for example, because it's ultra cheap nowadays. So it's just a couple of euros for a certain technology. So in the future, it will be very important to also prospectively evaluate that. But right now, for this specific case or for your daily practice right now, there is nothing that really can guide you through these situations.
Okay, I want to be very provocative with you all. So in case you have the possibility to use one marker, which one would you use?
For risk stratification right now?
Yeah.
So I think the molecular subtypes on non-muscle invasive disease are pretty interesting, but they do not apply for carcinoma in situ. You know, that's really a pity because I mean, carcinoma in situ, heavy extended carcinoma in situ alone is a very rare constellation in general. But I think that the Aarhus molecular subtypes are pretty profound for non-muscle invasive bladder cancer and that they could be used.
Very good.
Just to summarize, Oscar, maybe let's clarify there are no approved biomarkers for the diagnostic setting. So far, the guidelines do suggest that you could use somehow in the follow-up of high-risk patients in order to alternate cystoscopies, but nothing on this setting.
Okay, very good. And my last question in this specific setting of the case is for Dr. Pecoraro, is that, in my opinion, I think that in non-muscle invasive bladder cancer, the use of MRI is to rule out the presence of muscle invasive disease at the moment of diagnosis. So, specifically, can we avoid MRI? Can we avoid RET-UR with a good MRI? Or which is the specific role beside this point of MRI in non-muscle invasive bladder cancer?
Well, I think what MRI can help with is that in cases in which, you know, the outcome of the TURBT is non-muscle invasive, but it's a high risk, very high risk, then the MRI could help in identifying, you know, those that should not miss the RET-URBT. Like they have to do it as soon as possible. You have the window of 4 to 6 weeks, right? So it's actually to rule in rather than rule out who should avoid it, in my opinion.
Very good. Any other comments? Are you using MRI in order to rule out the presence of muscle invasive disease? Are you using MRI instead of RET-URBT? In our case, no.
Not in my case. Very hard to get the patients to have a bladder MRI.
Okay.
Yeah, I would echo that. I mean, we're not seeing MRI being used outside of trials, honestly, especially not in NMIBC. No.
Okay. So we move with the case. Unfortunately, this patient, after 6+3 adequate BCG, so in our institution, our protocol, those patients with CIS, we wait until the first maintenance to rule out the presence of CIS. So after an adequate BCG, everything was okay, negative, and the patient continued with the BCG maintenance.
I have a question, Oscar. Do you rule out with biopsies, or do you actually just cystoscopy and cytology is that enough? Because some, I mean, European guidelines, they do highlight the use of biopsy, but there are other places like Canada, for example, the cytology plus cystoscopy is.
So according to the results of the classic study of LAM, so the patients with CIS, presented a little bit more response after the first maintenance. So what we are doing is, after induction, cystoscopy and cytology. If negative, we go for the first 3 courses of maintenance, and after this, we are doing the random biopsies. And if negative, we continue with the maintenance up 1 year or 3 years or wherever. But we wait a little bit with more BCG in cases of CIS.
Marcus can tell us a little bit about the role of cytology within the context of BCG that can be somehow misguiding, I guess, because of the inflammation factors.
Mm-hmm. Yeah, that's a very good point, Carmen. Cytology is very difficult to interpret in the context of currently running BCG treatment, because BCG is usually leading to very heavy alterations in the urothelium that can mimic carcinoma in situ, for example. That is also the and it's very important also to state that this does not change in comparison to histology. Also, histology can be heavily biased by these reactive changes through BCG. So without immunohistochemistry, in the BCG therapy context setting, it's very hard to secure a CIS already on a biopsy. You really need a lot of expertise, and this should be a diagnosis that is not only done by one pathologist, but especially 2, ideally experts in genitourinary pathology. On a cytology, I would never dare to make a diagnosis of a CIS under running BCG treatment. That's a very dangerous decision, actually, because in the end, it could mean that the patient is losing its bladder because of a reactive change that is misinterpreted.
Thank you, Marcus. Please keep going, Oscar.
After this, the patient again has a positive cytology. We did random biopsies, negative, but after 2 months, the patient came to the emergency room with left back pain, with a normal renal function, and the patient had a CT scan where we saw a hydronephrosis, an important hydronephrosis, up to the bladder, with an important mass in the bladder, suspecting a muscle-invasive bladder tumor, a progression. So the surgeon could achieve a incomplete TURBT. I mean, he make the maximal TURBT, and in the end of the TURBT, the macroscopic viewing of the bed of the bladder was, in his opinion, that still was tumor there. And he put a double J in the urethra. So the result of the pathological was a T2, in this case, was a muscle-invasive bladder cancer. The base of the tumor was infiltrated for tumor, so it was at least a T2, no lymphovascular invasion, high grade. So in this case, I think this is very important question for the urologist. So in case we see an important muscle-invasive bladder tumor, we should go for as maximal TURBT in order to include the patient in a protocol of bladder preservation, improve the neoadjuvant treatment, or only with a biopsy is enough because we are going to do the cystectomy or the neoadjuvant treatment. So do you think that the TURBT muscle invasive should be maximal TURBT?
Maybe we can ask Ferran and Shilpa about their opinion here.
Okay.
Ferran?
Thank you. For me, radiochemotherapy is another local treatment, just as radical cystectomy, and it has to have neoadjuvant chemotherapy prior. So I think that this patient should have a neoadjuvant treatment, and then after, if we go for a re-evaluation and if we go for TMT, maybe try to maximize the TURBT. Though we have retrospective data showing that a complete TURB does not improve oncological outcomes, but still, I think I would do that. I don't know what you think, Dr. Gupta, about that.
Shilpa?
About the MRI PET. Yeah,
About
so
the need
we are not
of a
really
complete
doing
TURBT.
FDG PETs for bladder cancer patients. And as a part of the IBCG consensus also, we actually make that statement. It's not recommended unless there's a question we are asking, about a lymph node, which looks suspicious. But it's really only done in upper tract urothelial cancer patients, not in bladder cancer. So I'm not routinely doing it. And MRI, it is a challenge to get MRIs, believe it or not, here in the US. It takes a long time, then prior authorization and whatnot. So we're not really doing it routinely. But I would say that, MRI can provide that information like you were discussing, but it's not a standard that we can adopt right now.
And
Okay.
what about the completeness of the TURBT? Should you do it now, after neoadjuvant treatment? What would be your opinion on that?
Yeah, I would defer to the urologist, but I think in terms of BCG treatment, they're not really doing TURBTs each time unless there's something suspicious. That's what. So we're not routinely doing TURBT post BCG, at least not in our setup here.
No, Shilpa, the question is more if in this case right now, muscle invasive bladder tumor and an invasive mass in the bladder, if the TURBT should be as maximal as possible in order to improve the neoadjuvant chemotherapy or in order to include the patient in a bladder-sparing protocol.
Okay, yes. So for the bladder sparing, definitely, we want the maximal TURBT prior to starting the chemoradiation. However, for the neoadjuvant treatment planning, I think our expectation is as long as there is muscle in the specimen and we have a diagnosis, we get started with the neoadjuvant. But not for bladder sparing. For that, we definitely need a maximal TURBT when safe and feasible.
So it's basically mandatory for the trials, no? To be included, right,
Yeah.
Shilpa?
Uh-huh.
Okay.
Quick question for Oscar. Actually, two people asking the same question. Why did you decide to put a double J and not a nephrostomy?
Okay, this is the answer for this question is not a concrete answer. I think that if after the maximal TURBT you can see a nice hole in order to see what's going to happen with the patient in order to preserve the maximal renal function for neoadjuvant chemotherapy, it's okay. But also the possibility of infection during the neoadjuvant chemotherapy, it seems to be higher with double J. So in this case, might be better to go for a nephrostomy tube. What are we doing in general terms is if there is a hydronephrosis, the patient is going to go for neoadjuvant, and there is no impact in renal function, we don't put anything. The patient go for the chemotherapy, and that's it.
Sorry to stop you. I think one of the concerns of people was having a seeding of cells up when doing the double J. That was why they were asking.
This is another risk.
There is no evidence to support that. And I think the discussion is more about the nephrostomy because he has hydro, so he probably has a T3. So he definitely needs a Shilpa to give some chemotherapy.
Exactly. That's the point. If there is no impact in the renal function, we can go for chemotherapy. Otherwise, it's better to put a nephrostomy tube. In this case, the surgeon saw a nice hole and put a double J. Okay.
All right, let's move on.
Yes. How about is there any role for FDG from the radiology perspective in staging?
Yeah. Well, I think there's no sufficient evidence enough to use FDG PET in these cases. Perhaps FAPI, but again, there's no sufficient evidence. And concerning the other questions like the lack of access, I see that in the US it's difficult to get an MRI approval or what you said, Dr. Gupta. I see that I think that in Europe, if the subgroups of patients that would benefit the most are correctly identified, I think it would be an imaging that will be used in the future a lot, MRI. And as I was saying before, patients that need to undergo systemic therapy for the reassessment of response are the patient that will benefit the most. And concerning I don't know what you think, and just a little very quick information concerning pitfalls. The TURBT can cause some pitfall for MRI acquisition, but after 2 weeks, most of the inflammatory changes that are caused by the TURBT are gone, and the MRI is accurate. And second, BIRATS3, which is equivocal, it's different from prostate. Prostate, most of the time, the tree is a negative tumor, is like a negative patient. In bladder MRI, the studies have shown that BIRATS3 most of the time is muscle invasive.
Okay.
Yeah, and I wanted to pick your brain on, I know our colleagues in Italy are doing a lot of WIRADs. There's a dedicated radiologist. We here, like, we just don't have the resources. Like, we can barely get standard of care at. So what are your thoughts on like the practical applications of WIRADs? I mean, the potential is enormous, but I think the practical application is really very hard.
You mean the practical application related to the access?
For the WIRADs, to get that WIRADs MRI and the WIRAD score for bladder cancer patients.
Yeah,
For
well,
a dedicated radiologist to
you mean
dedicate all that time.
interdisciplinary agreement? That's what you mean, Shilpa? Like
Yeah, because you need a dedicated radiologist who can do WIRADs all day long.
Yeah, well, actually, the agreement between readers, it's very high. It's not as in prostate MRI. BIRADS MRI, I mean, bladder MRIs are much easier to score according to BIRADS compared to PIRADS. The differences between the readers are much lower. Consider that the lower K, so inter-reader agreement, is somewhere around 0.7, which is pretty high. So actually, the bladder MRI and BIRADS use, it's much easier than the corresponding on prostate. Yeah, so I don't see that as an issue.
Let's move forward. We need to discuss a little bit the bladder preservation inclusion criteria and neoadjuvant strategies with Shilpa. Maybe Oscar can keep going.
Okay. So this patient, after being discussed in our multidisciplinary team, finally went for radical cystectomy plus lymphadenectomy. And now here, I think that Shilpa, it's very important to really make an important summary on the indications of neoadjuvant chemotherapy or perioperative treatment according to results of Niagara, and which patients, also Dr. Achard, are the best candidates for bladder-sparing treatment in muscle-invasive bladder cancer. Shilpa?
Yeah. So I think, we recently published a consensus from the IBCG on the bladder preservation approaches. Can share the link. But I think in this case, patient had unilateral hydro, right? Only unilateral,
Yes.
right? So I think that is not a contraindication. Patient, we have to ask the patient, obviously nobody wants their bladder out. I think this would be a good candidate for bladder preservation. And while in the US, we are not routinely doing neoadjuvant chemo followed by bladder preservation, that's still a matter of clinical trials. We start patient on concurrent chemoradiation.
But do you agree that all patients with muscle-invasive bladder cancer, localized or locally advanced, should go for neoadjuvant treatment? Or do you consider that those that after a proper staging are muscle-invasive localized to the bladder wall should go for radical cystectomy, and neoadjuvant might be an overtreatment?
Yeah, no, I don't think they should all go to radical cystectomy for sure. I think, we are kind of lagging behind for bladder preservation. Like ideally, we should have a neoadjuvant chemo prior to concurrent chemoradiation, just like they do in UK and in Canada. But I would say that, anybody with muscle invasive disease should be discussed in multidisciplinary tumor board to allow the option of bladder preservation. I think that is the key. But to your point, I think it's going to be more and more with EV Pembro and already with GemCis, durvalumab, that we start neoadjuvant chemo thinking that a patient will have radical cystectomy, but then patients have such a great clinical response. And if they have achieved a clinical complete response, then it'll be hard to justify a cystectomy. So I think that will be certainly more and more what we'll see moving on.
Maybe
Okay, I
ctDNA
totally agree.
might help in that, Shilpa?
Yeah, I think ctDNA would be a good tool there. And then using the criteria for clinical complete response, which also recently was published in JCO, looking at MRI, looking at cytology, looking at imaging and cystoscopy.
So regarding to the question of ctDNA, the patient went to radical cystectomy, was a PT3A, and 5.
After neoadjuvant chemo?
No neoadjuvant chemo. The patient went straight for radical cystectomy. That's why I would like to really reinforce the message that neoadjuvant treatment should be really indicated specifically in those patients like this, where we have many things to consider locally advanced.
Oscar, let's give Beran.
Okay, so the patient received adjuvant chemotherapy and
let's
also
let radiation talk a little bit because we are over time.
Okay.
Yeah, thank you.
Chemo plus radiotherapy and negative CT scan and quick responses on ctDNA in this case for the follow-up and radiotherapy. Dr.
So I think at this point, yeah, ctDNA will just be for, getting the information, but patient already got adjuvant cisplatin-based chemo, so scans are negative. So yeah, it's a good idea to monitor ctDNA if there's access and availability. And if ever, I don't know, did you say it was positive at all or no?
No. After chemotherapy, everything was okay. Negative.
Okay, ctDNA was negative too. Yeah. So yeah, I think it's a good idea to monitor it, and if it does turn positive, to move up the scan. That's all we are doing. We are not basing treatment on ctDNA at this point.
What would you do if all the we have to?
Let's give a word to Beran because we are over time, so it will be the final comment.
Thank you very much. Thank you very much, Carmen. So I just want to stress out what Shilpa just said. I think the improvement that were made in muscle-invasive bladder cancer in recent years, it's really the systemic treatment. And now with the neoadjuvant treatment, we can consider the local treatment, whether it's radiochemotherapy or whether it's radical cystectomy, as a sort of adjuvant treatment for patient, a consolidative treatment for patients who respond very well. And if the patient progressed through neoadjuvant treatment, then the question is, will a radical cystectomy, will a local treatment will help this patient? And probably not. So I really want to stress that. I really do think, like in the UK guideline, that even patients with radiochemotherapy should have a neoadjuvant treatment before, because that's what really cured the patient. And finally, for the adjuvant radiotherapy, I think we will have more and more data about that. For the moment, it's a weak evidence on the EAU guidelines. But this year at ASTRO, Vedang Murthy presented the results of the BART trial, showing an improvement in local regional control in the arm of adjuvant radiotherapy versus observation after cystectomy for patients with high risk of local regional relapse. There will be meta-analysis. For the moment, there is no benefit in OS, just local regional control. But I'm pretty sure, that's my guess, that we will also witness a benefit in OS with adjuvant radiotherapy in the meta-analysis, but that's for the future. And then we will have to see how we can play between the adjuvant radiotherapy, the systemic treatment, and everything.
Thank you very much to everybody. Thanks to Laura, my co-chair. And I think we had a great discussion. I wish we could stay longer. We could actually do it because we have a lot of stuff to still discuss. Thank you, everybody, for joining. And I hope you have a great rest of the day.
Thank you.
Thank you.